All right, super. Let's get going. So let's just start off with our usual weekly announcements. The first is to make sure everybody is getting their CME credit. You can see here the code, the text, the code. We'll make sure that this information is in the chat box if you're just getting set up. It is different every single week, so you need to take note of this particular code today. And then looking ahead, we have two phenomenal grand rounds coming up. I think many of you may know that CAR-T has become a big focus for us in the Bass Center and doing great work in all kinds of CAR-T for malignancies and for solid tumors. And we're really excited that John DePercio is going to come from Washington University next week to talk to us about CAR-T for T-cell malignancies. And then the following week, what an extraordinary grand rounds to have Dr. Pizzo presenting about the global pandemic and a century bookended by the pandemics. I think this will be a really phenomenal presentation. And then next slide. Oh, and there you got it again, just for good measure. Thank you. And one more. All right. I want to make sure everybody has this on their books. The Maternal and Child Health Research Institute started annual symposiums a few years ago. They've been incredibly well attended. It's a way that we bring together the maternal and child health community across the entire campus, not just the School of Medicine, but we have really growing and good partnerships with a variety of the schools across campus. And the Maternal and Child Health Research Institute Symposium is a great way to showcase this. You can see here some of our faculty that will be presenting across multiple departments. And I also want to make sure you see that on the second bullet here that we're dedicating a whole session to scientific advances in diversity, health equity, and social justice. So please be sure to save the date and to join us. As you can see, it's going to be a really, really exciting program, and we're very proud of the work the Maternal and Child Health Research Institute has been doing, really very impactful, well beyond just the Department of Peds and even the School of Medicine. All right, next slide. So with that, it's my pleasure to introduce Jennifer Everhart. Jennifer is a clinical associate professor in the Division of Pediatric Hospital Medicine, and we're so fortunate that she's got a long history of collaboration with our grand round speakers. So Jennifer is going to introduce Dr. Khan. Jennifer, thank you for joining us.
Great, thank you, Mary, and good morning, everyone. It is my pleasure to introduce my friend and colleague, Dr. Alisa Khan. Dr. Khan is an assistant professor of pediatrics at Harvard Medical School and a staff physician and pediatric hospitalist in the Division of General Pediatrics at Boston Children's Hospital. Dr. Khan attended the University of Michigan Medical School and completed her pediatric residency at Johns Hopkins Children's Center. She then completed an academic pediatric hospitalist fellowship and a pediatric health services research fellowship at Boston Children's Hospital, earning a Master's of Public Health in Clinical Effectiveness from the Harvard School of Public Health. Dr. Khan's research focuses on family engagement in hospital communication and patient safety. She's participated in and led a number of studies looking at improving patient safety by promoting a shared understanding, whether that's between inpatient and outpatient providers at transitions of care, between providers and families overnight, or amongst the entire interprofessional team on patient and family-centered rounds. She's also looked critically at how we measure patient safety. She's developed innovative ways to engage patients and families in error surveillance and is currently funded by an AHRQ K08 award to operationalize and study a family safety reporting intervention and app for real-time in-hospital reporting. I've been a hospitalist for 11 years here at Packard, and during that time, I've seen our field grow and evolve. And one of the most exciting changes for me has been an increased emphasis on patient and family-centered care. Patient and family-centered rounds are becoming standard of care. We engage patients and families in shared decision-making, but there's still so much more work to be done. And Dr. Khan's work is an exciting next step, working alongside patients and families and the entire interprofessional team to co-produce safer care. As a pediatric hospitalist and health services researcher, Dr. Khan is challenging our traditional approaches to error reporting and patient and family engagement. It's my pleasure to welcome her here to Packard, albeit virtually, and I look forward to her presentation on engaging families as partners in hospital safety. Dr. Khan.
Thank you very much for that kind introduction, Dr. Everhart. It's a pleasure to be here, and especially special for me to be introduced by you. As Dr. Everhart said, I will be speaking today about engaging families as partners in hospital safety. And I wanted to start with a quote from a family advisor on our project, which is that we have to make it easier for families to be a true part of their children's care. When patients and families are true members of the medical team, care is more informed, more targeted, and more safe for everyone. And I think this really encapsulates why we do this work and sort of our guiding principles behind it. By way of background, medical errors and adverse events, as many as 250,000 annual US deaths can be attributed to medical error, which makes medical errors in hospitals a third leading cause of death. We define medical errors as mistakes in the care delivery process, and adverse events, which I will refer to as AEs, as injuries or harms due to medical care. And those can include those which are preventable, namely caused by medical error, and those which are non-preventable, namely those which are not caused by medical error. The role of the family is a critical one, and there has been a great deal written about the idea of families as partners or vigilant partners in care. And what this means is, and the reason for this is that families have an intimate knowledge of the historical background of their child. They have motivation for a good outcome. They have availability, proximity to the patient. And this may be particularly the case in pediatrics. As far as family engagement in hospital safety, we know that most hospitals don't actively solicit patient and family safety reports. And there's data to suggest that parents are frequently unaware of how to report hospital safety concerns. In a 69 hospital field study of child HCAHPS patient experience data, parents' lowest single rated measure was whether the hospital prevented mistakes and helped them report concerns, with an average top box score of only 55%. Despite this, there is a growing interest in the patient and family role in identifying medical errors and AEs. From a patient and family error surveillance standpoint, there are a number of studies over the past 2 decades that have indicated that there is a growing and important role for families in error surveillance. In a study by the Harvard School of Public Health, 23% of Massachusetts residents or someone close to them said that they or someone close to them had experienced medical errors in the past 5 years. And other studies suggest that 20% of patients report experiencing medical errors during care. And studies suggest that patients identify numerous valid errors and AEs that are otherwise undocumented in the medical error. And that many of these represent, on further validation, legitimate safety concerns, and only a few actually overlap with provider reports, suggesting that families are telling us things about safety that are real and that we might not otherwise know about. Hospital safety reporting as it exists currently operationally relies on voluntary hospital incident reporting systems at most centers, which we know capture only a small percentage of overall safety incidents and typically solely include providers. We know that providers are unreliable and only recognize and report 1 in 7 errors and harms that actually occur. And this is due to a multifaceted series of reasons that have been written about, including fear of reporting, fear of getting in trouble, fear of retribution, burden of reporting, being overly burdened with other clinical administrative tasks and not having the bandwidth. There's lack of recognition that things might constitute errors or AEs. There's also a diffusion of responsibility, the idea that perhaps someone else will report it, I don't need to. And then perhaps the most troubling one is the belief that certain errors are just too commonplace to report, and that if we really sat and reported everything that happened, we would spend a significant chunk of our day doing so. So this gap sort of highlights the role that families could potentially fill in allowing hospitals to better understand the true nature of safety. So we have led a series of studies looking at family safety reporting in the pediatric inpatient setting. The first one of these was several years ago when I was actually a fellow. We integrated safety screening questions in a discharge experience survey that we were conducting for another study. And we found that 8.9% of families reported safety concerns through this discharge survey, where essentially we were asking 2 questions: whether they had experienced a mistake or harm due to care, and whether that had led to harm. The majority of these concerns were found to be medical errors upon further validation. and many were not documented in the medical record. And we found that children with certain complex chronic conditions had more parent-reported errors, and that parents reported preventable AE rates of 1.8 per 100 admissions, which is actually quite high and similar to sort of more sophisticated medical record review-based active surveillance methodologies that are frequently used in research and which typically include only providers, and which we'll address a bit later in the presentation. So we published a study in JAMA Pediatrics in 2016, parent-reported errors and adverse events in hospitalized children. And this garnered some press in the lay press, Reuters, and the headline they put was that mom and dad often catch hospital errors doctors missed, which is perhaps not exactly how I would frame it, but it's not entirely untrue, and I think is an important message. We built upon this work and wanted to look at the role of family safety reporting as compared to the current sort of gold standard methods for systematic safety surveillance, which are predominantly used in safety research and not necessarily operationally. But we wanted to see if we integrate families into that sort of gold standard safety surveillance methodology, which is considered sort of the gold standard for how you measure hospital safety in research studies, what will their added yield be, and what will we find? So we piloted a methodology to integrate family reporting into this systematic safety surveillance research methodology. What we did was we conducted weekly and at discharge in-person semi-structured family safety interviews. And then each of the errors and AEs gathered through these family safety interviews underwent the same subsequent two-step validation, which I'll show you in the next slide, that any other suspected error AE would undergo. And we applied this to systematic safety surveillance that we were conducting in the multi-center patient and family-centered IPASS study, which I won't talk about at length today, but which we published in the BMJ in December of 2018, and was an intervention to improve family-centered communication and examine its impact on patient safety. And we found that that intervention was associated with a 38% reduction in preventable adverse events, preventable AEs. But back to this novel family error reporting methodology. In order to develop this, we partnered with family advisors through the Patient and Family-Centered IPASS study group. We developed, some of whom include individuals here at Lucille Packard, including Michelle Anderson, who is one of the lead parents. We developed, piloted, and cognitively interviewed our parent safety interview guides, and we oriented parents to error types and examples, for instance, medications, miscommunications, diagnoses, delays in care, complications of care, and equipment failures. And then we specifically asked families using kind of more family-friendly language and definitions of these things about AEs and harms, about errors of omission, commission, non-harmful errors, and then about other issues they had encountered. And as I mentioned earlier, we conducted these parent safety interviews at discharge and weekly. And so we integrated the family safety interviews into the existing systematic safety surveillance process that that is used and is typically considered the gold standard for systematic safety surveillance. And so in that process, typically what happens is in the first step, nurse data extractors collect suspected errors and AEs that they have obtained through provider reports, through hospital incident reports, and through daily chart review. In the second step, pairs of physician reviewers independently review and classify each of these events as either AEs, non-harmful errors, or exclusions. And as you can see, the typical process that's considered a gold standard does not include any information from patients and families. So our process integrated the family safety interviews into that first step, whereby family safety interviews would be considered equal to any other source of safety data, whether it was provider reports, hospital incident reports, or daily chart review. And then they would undergo the same rigorous two-step validation process as any other source of suspected errors or AEs. And so what we found when we implemented this in across 4 study centers across the US and Canada, we found that 25.8% of parents reported safety concerns during these family safety interviews. and that they identified several otherwise unidentified preventable AEs. One example of these is an example where a patient was in the ICU and transferred to the ward. They vomited and had trouble breathing, and the mother found her, and then the parent reported that the nurse did not suction or as needed or requested by the mother, and that the patient was choking in this event. And this was an event that was not otherwise documented in the medical record or in a hospital safety incident report or through provider sources. And so this figure comes from the paper we published on this in JAMA Pediatrics in 2017. But on the left, you'll see a series of Venn diagrams, or a Venn diagram that looks at the validated medical errors that we found in that study. And on the right is the validated AEs. And so you can see that A is errors that were obtained, that were detected on medical error review. B is in green, those are errors that were detected by families. C is those detected by clinicians, so physicians or nurses predominantly. And D are those through hospital incident reports. So I think what's really notable here is that while medical record review is the largest source of safety events, families are a very notable source, and we're actually not seeing a ton of overlap between families and clinicians. So families are providing information that clinicians aren't. We also aren't seeing a ton of overlap between families and the hospital incident reporting system in orange. And then the segment of the Venn diagram in green that's external from the others, those represent the incidents that we wouldn't know about if not for the families. And similarly, we found that for AEs, there was little overlap between family reports of AEs and clinician reports. A little more overlap, I would say, with hospital incident reports, and still a proportion of reports that we wouldn't know about if not for the family reports. And I should point out that, again, the hospital incident reports only represent a small fraction of the 179 sources. They only represented 5 errors, and for AEs of the 113 hospital incident reports only represented 7. So if we look at sort of what is typically happening outside of a sort of research context, typically what the hospital is systematically identifying and tracking is that orange section, which is really just a drop in the bucket. And if you were to look at the family section, that would actually represent a lot larger than what we're obtaining from hospital incident reports, which I think is a really interesting finding. So we then looked at actual rates to compare them. And so we looked at overall medical error and AE rates with and without family reporting. So the graph on the left represents that. The x-axis is on the left are errors, and on the right are adverse events. The y-axis is rates of these events per 1,000 patient days. And you can see that and in gray is represents rates without family reporting, and in black are rates with family reporting. And so you can see that our rates of errors without family reporting were 39.7 per 1,000 patient days, as compared to 45.9 per 1,000 patient days when we included family reports. So our including family reports increased our rates of errors by 15.6%, and that was statistically significant. When it came to adverse events on the right, including family reporting increased the rates of adverse events by 10%. And I should add that these are events that have undergone that 2-step classification, so have been verified by a nurse and then the pairs of physicians as being indeed true errors and adverse events. And then on the right, the graph shows hospital incident reports versus family reported medical error and AE rates. And so on the left are errors, again, and on the right are adverse events. The y-axis is again rates per 1,000 patient days. In green are hospital incident reports, or in gray, excuse me, are hospital incident reports, and in black are family reports. And so you can see that our rates, if we only looked at hospital incident reports versus family reports, our hospital incident report rates are 1.7 per 1,000 patient days in that study, as compared to 8.7 per 1,000 patient days if we look at just family reported errors. And then for AEs, if you looked at just hospital incident reported rates, we would get 2.4. And if you looked at just family reported rates, we would get 6.9 per 1,000 patient days. So essentially, families are reporting errors and AEs at rates that are 5 times higher errors at rates that are 5 times higher than hospital incident reports, and AEs at rates that are 3 times higher than what we're obtaining through hospital incident reports. We also compared family versus provider reporting rates to look at the yield when you compare families versus providers. And we found that there was no statistically significant difference for errors and AEs, that essentially families and providers were providing statistically equivalent rates of errors and AEs. So I think these results really, I think, underlie the fact that families are actually very good at reporting errors and AEs, and may be better at it than we give them credit for, and may be just as good at providers as doing it, if not better, and maybe higher yields than what we're finding through just our hospital incident reports currently. So we also did some multivariate modeling to look at predictors of family reported errors and AEs. And in the first column, we were looking at errors, the first 2 columns, and those are rate ratios and with 95% confidence intervals and p-values. And then in the right column, we are looking at AEs. And so we found that characteristics associated with higher rates of family reported errors included having younger patients, having patients with 1 or more CCC, or a complex chronic condition, which is basically just an ICD-9 or ICD-10 code identified marker of medical complexity. And then some of the parent characteristics associated with higher rates of family safety reporting for errors included higher patient age and higher patient education. So those with some college or more were more likely to report than those with less than a high school education. For AEs, we found similar findings, but mainly we found that children with higher complex chronic condition numbers and whose parents had higher education were more likely to report AEs. And the question is, how much of this is patient factors versus kind of reporting factors, or some combination thereof, but it certainly provides some interesting food for thought. We published this in 2017, and again, this picked up some press, and they said that family reported errors may go undocumented on hospital records, which I think is a really accurate characterization of what we found. The conclusions of that study were that families report errors and preventable AEs quite frequently, and that they can provide important complementary and unique safety data, and may contribute equally to providers and safety reporting. And that children with complex chronic conditions have higher rates of parent-reported errors or adverse events. It's unclear whether that's because they're more predisposed to safety, or because their parents are more activated and familiar with the healthcare system and thereby more likely to speak up, or some combination thereof. I personally suspect it's some combination thereof. However, the best method for operationalizing family safety engagement and reporting in hospitals remains unknown. So our next step was to conduct a study that I'm in the process of conducting as we speak. It's called the Family Activation and Communication About Errors and Safety Study, which, as Dr. Everhart mentioned, is funded by the Agency for Healthcare Research and Quality as part of a K08 Career Development Award, as well as the Hood Foundation and other private sources and foundation and institutional sources of support. But by way of background, as we demonstrated through some of our studies and those of others, families of hospitalized pediatric patients are good at identifying medical errors and AEs, particularly children with medical complexity, as we alluded to. And we define children with medical complexity, or CMC, as children with multifaceted clinical and functional needs that can be difficult to manage. These are children who represent less than 1% of the pediatric population, but represent a significant portion of healthcare costs and readmissions. And though we know that patients and families are interested in being engaged in safety efforts, and that providers support their involvement, family engagement and safety reporting has not yet been operationalized in most hospital settings. And we know that there are a number of barriers for this. A conceptual model for hospital family safety reporting is on this slide, and it is adapted from the health beliefs model by Glanz et al. And so we can see that there are individual perceptions that underlie the ultimate outcome, which is the likelihood of reporting. And so that can be perceived susceptibility to, severity of, or recognition of a safety event by families. They're modifying factors, including age and sex of the patient and the family member, medical complexity, activation of the patient and family, socioeconomic factors, knowledge, health literacy, education. Some of the cues to action can include, and those are sort of modifiable things that we as a healthcare system can, and we as providers can potentially intervene upon, which include things like training, activation, communication with families, having a reporting tool or mechanism, ensuring psychological safety and psychological security. And those factors work together to determine the family's perceived risk of reporting the event. And then it's sort of a calculus. Their likelihood of action is a calculus between the perceived benefits minus the perceived barriers to reporting. And so this framework sort of underlies our approach in the FACES study. The objectives of which were to understand, using quantitative and qualitative methods, patient, parent, and staff experiences with family safety reporting. 2, to develop an operational family safety reporting intervention for children with medical complexity. And 3, to test whether implementation of this intervention is associated with improved rates of family safety reporting and experience with safety. The methods, this is a mixed methods study that, as I alluded to earlier, utilizes both qualitative and quantitative methods. The setting was the inpatient complex care services units at 2 tertiary care academic hospitals. The timeline was a 3-year period from 2018, and it's ongoing as we speak, slated to end in 2021. And the timeline for this study is a 12-month pre-intervention period of qualitative and quantitative data collection, followed by a 12-month intervention development and refinement period, followed by a 12-month post-intervention period, which is ongoing and which I will fully disclose has been shifted with the COVID-19 pandemic. And we've actually had to pause a bit to get some additional COVID-19 era baseline data, because when the pandemic struck, we were sort of in month 2 of post-intervention, and we realized we couldn't really, that we needed to sort of reestablish a new baseline. So the data I will share is kind of mostly pre-COVID, but will be ongoing, and we'll have more data that we're collecting currently. The participants in the study included Spanish and English-speaking parents of children with medical complexity hospitalized on the CCS, or complex care services, and physicians, nurses, and hospital leaders. Our quantitative approach was to conduct staff surveys, which were mostly a convenience sample, and parent surveys, which were systematically conducted prior to discharge from the CCS service. And we asked both staff and parents about their experiences with family safety reporting and their kind of overall hospital experience. We also collected sociodemographic information, health literacy information, parent activation, and other factors, and hospital safety culture scores. We conducted the quantitative portion of the study at 1 hospital. After we collected reports from families, 2 trained physicians independently reviewed and classified family safety reports, and we conducted chart review when there was insufficient information to classify the event. 17% of the reports underwent a dual physician reliability check, for which the kappas are quite good, as you can see, a kappa of 0.77. And then we used mixed effects logistic regression with random intercepts, controlling for clustering by participants, to identify characteristics associated with families reporting safety concerns. For the qualitative portion of the study, a team of physicians, nurses, and research staff conducted approximately 45 to 60-minute semi-structured individual audio recorded interviews of parents, nurses, physicians, and hospital leaders of hospitalized children with medical complexity, and this took place at the 2 hospitals. The interviews were audio recorded, transcribed, verified, and coded, and we used a thematic analysis to identify emerging themes that reflected commonalities across stakeholder groups, and the interviews continued until thematic saturation was achieved. And those interviews are nearing completion, but we're going back and conducting some additional Spanish-speaking interviews of families. So some of the topics that we asked in our semi-structured interviews included, for parents, we asked about cultural and other beliefs about speaking up with safety concerns, their reactions to reporting options and their preferences. So do they prefer online versus paper? We asked about the implications of reporting on their trust in the hospital and their experience with the hospital. For nurses, we asked about their feelings about families speaking up, about their comfort with inviting families to report safety concerns, about their experience with families reporting safety concerns. For physicians, we asked many of the same questions as we asked for nurses, including importance and feasibility of soliciting reports from families, their belief about their physician role in soliciting family safety reports, and their experience with safety reporting with families from different backgrounds. For the hospital leaders, which included leaders from quality, safety, legal, patient experience, patient safety, we asked about legal and other concerns related to family safety reporting. We asked about processes and preferences for addressing safety reports in real time, and about their sort of leadership and hospital perspective on their willingness to include families in safety reporting. What we found from the surveys was that only 31% of parents, or 41 total, stated that staff told them how to report concerns about mistakes in their child's health care. So not dissimilar than what we found in what I alluded to earlier in the presentation with the child HCAHPS 69 center data. In fact, these were even lower scores than were suggested in that multi-center data. We found that 43% of parents, so 67 of them, reported safety concerns during hospitalization, which is essentially almost half of these. And as a reminder, these are parents, again, of hospitalized children in medical complexity, so perhaps patients that are at a higher risk of experiencing errors and AEs at baseline, but essentially almost half of families were reporting concerns. Most of the parents, interestingly, 64% of them had reported their concerns to the hospital, primarily verbally to their bedside nurse. However, only 16.6% of staff stated that a parent had reported a safety concern to them in the past week. And I should note that we weren't doing a one-to-one match, so we weren't asking the same patient's nurse and the same patient's parent whether they reported a safety concern. So it was a little bit like two samples, if you will. We classified the family safety concerns. Though 67 families reported concerns, they reported more than one concern in many cases, reporting between 1 and 6 concerns each, and for a total of 115 family safety concerns. Of those, 79 were deemed safety, so about 69% of them. 25 were deemed non-safety related quality, so things like communication problems, environment or room problems, resource availability, privacy, or cares. And then the remainder, 11, were medical care concerns deemed neither safety nor quality problems. They were things like, we wanted to get an MRI and the MRI didn't happen. And then when we further did a chart review, it seemed like that was kind of appropriate clinical decision-making. So those were sort of more differences in opinion around care rather than actual safety or non-safety related quality concerns. But I would argue that, the majority of these were safety concerns, but a large proportion were, I think, valuable quality related concerns that the hospital would be interested in hearing about as well. Among the safety concerns, 21 were harmful errors and 58 were non-harmful errors. The most common categories were medicines or IV fluids, followed by equipment, followed by procedures or surgeries. And then they also reported about hospital-acquired infections, diagnoses, other therapies like vests or casts, and fall risk. Among the non-harmful errors, there were a lot of medication and IV fluid related errors, as well as errors around feeds. Many of the children with complex, with medical complexity in our sample had G-tube or J-tube feeds and enteral feeds, and so there were issues with rates and timing of those. And then equipment problems, diagnosis problems, environment, and other therapies after that. We surveyed a total of, we received completed surveys from 155 parents and 214 staff, which included nurses and physicians, both resident physicians and attending physicians and fellows. And we had over 89% response rates. And so overall, our parent characteristics, our mean age of the parents was 48. They were predominantly female, mostly mothers. The race and ethnicity distribution, they were 73% were white, non-Hispanic, 11, almost 12% were Hispanic, 5% were Black or African American. As far as their English proficiency, 11.8% had limited English proficiency, and as far as their education level, just about half had completed college and a little over half had not completed college. Their income, 46% had an annual household income under $50,000. And as far as health literacy, 16.8% had limited health literacy. Patient characteristics, the mean age of the patients was 13.8. As children with medical complexity, their mean age was perhaps a little higher than on some of the typical general pediatric services. They were slightly more male predominant. They had been admitted to the hospital in their lifetime several times. 27% had been admitted 9 times or less. Over 50% had 10 or more admissions lifetime. And they had been part of the complex service for a mean of 7.5 years. Almost 50% had a length of stay over 5 days, and 52% were commercially insured as compared to 31% which were publicly insured. Some examples of the family safety reports made by families of children with medical complexity. There were a number of categories that they reported, including devices, diagnoses, environment, equipment, fall or fall risk, feeding, hospital-acquired infections, and medications. And I won't read them in detail, but essentially for the device, they talked about having an error where they thought nerve blockers were an epidural and the patient was receiving an incorrect amount of pain medications for 12 hours after surgery. For diagnoses, there was a delay in diagnosis of intussusception where the family had advised hospital staff that the child's abdomen was bloated and was constipated, and they had requested a GI consult, which wasn't conducted for several days, and there was fluid out of the G-tube. With the environment, there was a case where a child was left alone with a toy that they almost choked on, and the family made a good catch there. There were a lot of equipment-related reports, for instance, braces not being used for children who have chronic CP and who are at risk for further contractures. Fall risks, there were reports of forgetting to close the posy bed, again, for children who may have neurological impairment and maybe fall risks. There were, as I mentioned, a number of reports about feeding ratios being incorrect, and then there was reports of infections such as C. diff. This is an example of a report that came in Spanish, and the translation is basically that there was a delay in obtaining the seizure medications, and it was a 2.5-hour delay for the medication to be administered. We looked at some of the multivariable associations between parent and patient characteristics and families reporting safety concerns, and not dissimilarly to some of our prior work, we found that families with higher education were more likely to report safety concerns, and families with a higher length of stay. And this also adjusted for race, ethnicity, language proficiency, health literacy, patient age, and number of hospital admissions. Switching gears to the qualitative findings, we interviewed a total of 65 parent, physician, nurse, and hospital leaders individually. That included 19 parents, of whom 6 to date are Spanish speaking, and we're working to get some additional Spanish speaking families. 11 were physicians, 15 were nurses, and 16 were hospital leaders. Some of the emerging themes we identified around family safety reporting included individual factors that affected family safety reporting. So some of the concepts within that were feeling trust, feeling listened to, a fear of retaliation. There was a great fear expressed by families that if they speak up, their child might not get the care they received. Some families talked about how that used to be a fear when they first started out, but then over time they realized that wasn't the case. On the flip side, it was interesting, there were several staff that reported that families, when they were identified or labeled as being difficult, staff would avoid entering those rooms, and that might then in turn lead to safety issues. So sort of suggesting that though we sometimes provide reassurances that there is no fear of retaliation, that may not entirely be the case, which I think was a really surprising and kind of sobering finding. There were also factors around hierarchy, both between physicians and nurses and between families and physicians and nurses. And then there was this calculus of weighing the risks and benefits of reporting, kind of like we identified in the conceptual model, where families were saying, is it really worth it? I'm gonna pick my battles. is this really that big a deal? And often having to make that judgment of whether or not they speak up and what the impact might be on their child. Some of the organizational factors affecting family reporting were another emerging theme. We found that the organizational culture was really important, and that was often set by leadership about whether, for instance, hospital safety reporting was encouraged or not, whether staff were supported in when an event happened, whether they felt like essentially they had the support of their managers. And the other factor in this, the other concept in this theme was limitations of existing reporting processes. Which was that though reporting processes exist, families don't always know about them, whether it's patient relations or speaking up, and that those are not always reliably documented. Some of the motivations for reporting that were identified included improving systems, preventing harm to other patients, recognizing that safety is everyone's responsibility. That was really a kind of shared feeling across all groups. And this recognition that errors can happen and that there is sort of a fact of the hospital being a place that is error prone. Some of the strategies to facilitate reporting that we identified included flexibility and simplicity in reporting mode. So people were saying that options are important, that for one family, they may prefer an electronic, others may prefer on paper. I think everyone recognized the family's expertise, and this was kind of an important thing that was identified by families and staff and leaders alike. There was also an importance placed on addressing family concerns appropriately, on providing language for families to report. So providing a language that will allow, and terms that will sort of allow providers to recognize the gravity of what's being said and to take it seriously. And then there was also family and staff education was another identified concept around strategies to facilitate reporting. So in conclusion, with the FACES study to date, we found that parents of children with medical complexity frequently have valid safety and quality concerns that may be otherwise unrecognized, and that less educated families may be less likely to engage in reporting, suggesting efforts to engage more disadvantaged families are needed. We also found that parents, at least especially of this population, often report concerns to the hospital already, mainly to their nurses, despite being infrequently told how to report concerns. However, it's unclear how many of these reports are actually tracked by hospitals, given that we know from prior work and from the literature that hospital staff infrequently report concerns in hospital incident reporting systems. And in that prior study with the Venn diagram, we saw there was so little overlap between the family concerns and the hospital incident reports. And then a conclusion of this is that we believe that hospitals should provide clear mechanisms to engage families in sharing safety concerns, for instance, engaging them in incident reporting systems to help identify otherwise unrecognized areas to improve safety. That brings us to the intervention that we have developed and are in the process of preliminarily testing as a result of this work. And so essentially, in addition to the in-depth qualitative feedback from each stakeholder group, we developed this intervention through convening a multidisciplinary working group of parents, nurses, physicians, researchers, and hospital leaders to develop and refine the intervention. We met bi-weekly over a 2-year period. We also met regularly with hospital and complex care the Family Advisory Council, with hospital leaders across various domains, and solicited continuous input as we iterated the intervention. And this intervention was further informed by communication science, health literacy, and organizational behavior principles. Some of the communication science principles include utilizing exemplars. So those are illustrative in individual cases. So we used photos of children and their providers from the actual units in our educational materials, in our brochures and our signage. We used issue framing, which is basically defining an issue by emphasizing a subset of potentially relevant considerations. So we framed the issue around families as experts, and we want to know, as that was something that was sort of was universally agreed upon by all of the stakeholders. We also used grant gain framing, which is describing a choice in terms of its positive features, namely help us make care safer for your child and all children. And then we centered patients and families of diverse backgrounds in each picture. We also used activating language to encourage families to speak up, including a quote from our family advisor, Helen Haskell, who is the president of Mothers Against Medical Errors and a collaborator on this work. And based on the fear of retribution that was expressed in some of the qualitative interviews, we reassured families that sharing concerns would not affect care. Some of the health literacy principles we included were audiovisual redundancy, basically so that both visual and auditory learners will be able to learn best. So when we had a brochure, and I'll show all of this later, with families. And when we distribute it, we made sure to go over it in person, which is an important health literacy best principle for written documents, that you don't just hand something to someone, but you review it with them and allow them the opportunity to engage and ask questions about it. We used plain language, so materials had a 5th or 6th grade reading level. We defined terms like safety, and I think that was something that was really important, because when we first did this work, I think we thought everyone knows what safety means, but as we learned from our family advisors early on in some of our prior studies, they said, safety could mean different things to different people. Do they mean, physical safety, like slipping in the hospital, or do they mean an active shooter? What does that mean? And so that was a really important piece of feedback that we learned from families. And so we tried very carefully to define what we meant by safety. We also vetted our language with health literacy experts, and then we piloted it and cognitively interviewed materials with individuals from diverse educational and health literacy backgrounds. I won't go into great detail about this in the interest of time, but we incorporated organizational behavior principles. And so one of the organizational behavior frames models is the 4 frames model, which essentially means that when you look at organizational behavior, you have to look at structural systems, so systems and processes, political systems, so individuals conflicting agendas, coalition building, conflict resolution, symbolic aspects, so the need for purpose and meaning, having a motivated vision, recognizing performance, and then human resources, so giving individuals power and opportunity to perform tasks while addressing needs for growth and contact and satisfaction. So we tried to ensure that when we developed this intervention, we addressed each of these and had a formal mechanism, made sure that our tool interfaced with existing structures, established relationships with stakeholders, included frontline staff, as well as families, safety, quality, patient relations leaders, and then had a shared vision, namely that families are experts in care. We can all work together to make care safer. And then used, actual signage and photos from patients and their families, and then partnering with the unit leadership and emphasizing creating roles for individuals and emphasizing QI and scholarship benefits. So with that, the pilot intervention we've developed is Families Partnering for Safety comment card, family education and activation, provider training, which includes PowerPoint, staff meetings, posters in bathrooms, locker rooms, workrooms, and then sharing learnings with clinical and hospital leaders. This is a picture of the front of our family brochure, and which includes one of the providers and a patient and his family. And then the electronic family safety comment card, which we actually had a paper version pre-COVID as well, which we decided to do away with and focus on just the electronic for infection control reasons. So now it's just an electronic version, but it has several questions about, do you have any safety comments, suggestions, or concerns, good or bad, about this hospital stay? And we give them categories, and then we have them tell us about it and where it happened. And then there's staff education, which includes language to encourage patients to speak up, parents to speak up, and tells them about the study and the process and the reason. We have approached, prior to our COVID pause, we had approached 24 families and got comment cards from 63% of them, mostly on paper. So we'll have to see what happens when we pivot to only electronic. And we found that 50% of families shared a concern. So some of the families also shared compliments around staff being supportive, being careful to know the difference between the G and the J tube, trying multiple ideas before going to anesthesia, good sanitation practices around catheters and blood draws. Some of the concerns we found were around medications, and these are all from the comment cards, around dosage and time, getting pills when the child only takes liquids, being concerned that the fluid intake was too low, so asking for IV fluids. This is a screenshot of part of our brochure, which includes a QR code through which families can use the electronic safety comment card. We also send them emails and text messages if they give permission. Other comment card responses included communication concerns. This is a story where a child is prone to having seizures and will sometimes snap out of it if you yell the child's name. And so this was an example where the family was afraid they were going to have a seizure and felt dismissed by the nurse, who said, well, their oxygen saturations were okay. And so the parent said, I know my son better than any nurse. I just want to explain what can happen. I don't like feeling stupid because I don't have a nursing degree. And then some feedback about having more consistency and about information being lost or misinterpreted, like times for medications. There were also concerns about diagnosis and evaluation, like delays in imaging, environmental concerns like fall risk because of the commode being too large, some environmental things like trash bins being too loud, being cautious about infection control, which is more pertinent than ever in the COVID era, cleanliness, contamination, feeds, and medication timing. So our next steps are to test the FACES intervention in a larger patient sample post-COVID using only the electronic version of the comment card and to examine reporting rates and experience. And after that, we plan to conduct a multi-center implementation and randomized controlled trial of FACES. So in conclusion, parents are true experts. I hope that I've shown that they share valid safety and quality information that might otherwise go unnoticed. And that they actually do speak up a lot already, though it's not clear that we effectively track their concerns on a systems level. A lot of what happens is sort of triaging individually and addressing things locally, but not necessarily systems wide. And partnering with families for safety improvement can help identify and prioritize otherwise unrecognized areas for improvement. So we recommend that hospitals provide clear mechanisms for families to report safety concerns, whether it's including them in incident reporting systems, setting up additional processes for them to report, surveying families about safety at discharge, and that buy-in from frontline staff and leadership is critical. We think that FACES may be a means to effectively engage families in safety reporting, but is clearly one that we are planning to test further. And that in the end, we need to ask and listen and track and act. And I wanted to end with a quote from Helen Haskell from Mothers Against Medical Errors, one of the collaborators on this study. The families are the eyes and ears of the healthcare system. They bring a fresh perspective to things people working within the system may not think to question. I think the wisdom of families is the ultimate secret to making our hospitals safer. And I wanted to acknowledge my mentors and collaborators and the Patient and Family Center IPASS study group, including some individuals here at Stanford, including Lauren Destino and Dr. Jennifer Everhart and Michelle Anderson. And our funders, including the Agency for Healthcare Research and Quality and the Hood Foundation and other organizations. And I am happy to entertain questions. And this is our study team.
Thank you so much, Dr. Khan, for an excellent talk. There are lots of comments coming through and many congratulations and thank yous for the work that you're doing. One of the questions initially was around just reiterating the limited English proficient patients and families and their likelihood to report errors and adverse events. And then a follow-up to that being, how do we improve that reporting among some of our underserved or marginalized patients and families? How do we empower them to speak up when they may mistrust the system and are perhaps at increased risk of adverse outcomes?
I think that's a great question and a great point. I don't think we had the power to see that they were reporting less. So our numbers and our kind of multivariable analysis didn't necessarily suggest that there was a difference by language proficiency, but I suspect it was just that we were underpowered to see it because I do think that there is a discrepancy. And in some of our qualitative work, we have found that families, share that there are additional barriers and staff share that there are additional barriers where they see that families with limited English proficiency aren't always able to find the resources to have interpreters or to kind of speak up. And I think something that's so important with our families with limited English proficiency is there's so many ad hoc communications that happen in the hospital setting that I think fundamentally aren't interpreted. And so if you think of a family who speaks English, every time a CA comes and does vitals, or a nurse checks the IV, or someone comes, each of those are opportunities where the family can speak up, ask a clarifying question, express the safety concern. And what the literature suggests is that with families who have language barriers, they're only getting an interpreter maybe like 1.5 times a day. So clearly all of those ad hoc communications are not being interpreted. And those are all sort of missed opportunities for engaging and speaking up about safety. We actually have a paper coming out Monday in JAMA Pediatrics, which suggests that families with limited English proficiency have twice the rate of hospital adverse events. And so I think, though our data hasn't shown it, I think we were underpowered to see that. And I suspect that it is an issue. And I think some of the solutions are to engage interpreter services at all aspects of care. And I think to engage families and normalize things and really encourage reporting and take extra care to do that with families that may be disadvantaged because of language or education or other barriers.
Mm-hmm. How do you see family-centered rounds playing into this? Is there an opportunity there to engage and screen for medical errors?
I think so. In some of our qualitative interviews, people definitely talked about how family-centered rounds are an opportunity to engage. In the patient and family-centered IPASS study, which I didn't go into great depth about, but as Dr. Everhart can attest, one of our guiding principles is that you start by eliciting questions and concerns from the family. And I think that empowers families to speak up and is an additional opportunity for them to speak up and share concerns. So I think it is a great opportunity. I think it's not enough. I think those ad hoc communications and I think providing other avenues are there too, because the other thing we hear from families is that on family-centered rounds, sometimes it can be intimidating to speak up. There are lots of people there. They may be tired, sleep deprived. It may be early. They may be having someone come in at 5 a.m. From a subspecialty group. And so I think family-centered rounds are definitely an opportunity, but I think what we've learned is we need all the opportunities we can get. We need multiple modalities and multiple systems, and we need to actively ask.
Thank you. Several comments and questions were around system aspects like nursing ratios, for example. How does that play into the rates of medical errors and likelihood of families reporting them?
Yeah, I think it's a great question. We found in our quantitative work and in the qualitative work that families often report more to their nurses and kind of have more proximity and relationships and trust with their nurses because there's more face time. And it's an interesting point because as a corollary, if nurses are having higher patient ratios, they may not have the time to establish those relationships or facilitate some of that communication. So you can see how it might lead to some erosion of the opportunity for the families and nurses to engage. I think in this research and in some of our other work, there is really sort of a secret sauce in the relationship between nurses and families that I think directly impacts patient safety and experience. And so I think there is something special about that relationship that is really important that we need to figure out. And I think that safety reporting is one of those examples. And I think providing nurses with tools and physicians with tools so that, if a family reports to them, it would be great for a family to be able to report verbally, yes, but then to also be able to share through a kind of a third party source, whether it's family safety reporting, hospital incidents reporting system for the family, or a hotline or something that is manned by the hospital so that the burden doesn't fall on the family, the nurse or the physician who's already busy to translate what the family said and then report on their behalf, which we know doesn't really happen. So I think it's complex and there are many areas in which we can address it.
I think we're getting to the end of our time. So perhaps our last question would be, can you speak quickly about any potential pushback from legal departments or risk management, and how do you message this with those departments to let them know this is worthwhile?
Yeah, that's so important. We spent a lot of time talking to the legal departments at both of the study institutions, and I think they are cautiously optimistic. I think framing it as, I think for them it's important that this be integrated into existing systems. And I think they also sort of fundamentally have sort of a common sense approach that they've expressed, which is that sometimes when it comes to litigation, you find that families are upset because they're not being listened to. And so if you provide mechanisms for listening and hearing, you may actually obviate some of that litigation. So it may have an opposite effect, but it certainly has to be thoughtfully constructed and done in conjunction with legal. I found them less risk averse than I would have expected. I found that the legal groups were quite thoughtful about this, but definitely it's something that needs to be thought about and considered for sure.
Great. Well, we unfortunately didn't get to all the questions. Thank you everyone for your very thoughtful comments, and thank you Dr. Khan for a wonderful presentation, and I wish everyone a safe and healthy weekend.
Yes, thank you so much everyone.
The preceding program is copyrighted by the Board of Trustees of the Leland Stanford Junior University. Please visit us at med.stanford.edu.